Official hello. Thanks, Kate, for joining our Grand Round series in cardiovascular imaging, our second Grand Round series, which we organize together, the Department of Radiology and the Department of Cardiology at the University Hospital of Zurich. It's a great pleasure that we have you with us today as an expert in cardiovascular imaging. You are the director of cardiac imaging research at the University of Toronto in Canada. And I know you did a lot of research and highly interesting research in particularly MR imaging in COVID-19 and also vaccination, post-vaccination myocarditis imaging. So we are looking forward to your presentation, and thanks again for being with us.
Thanks so much for inviting me. Really, the honor is all mine, and this is one of my favorite topics to talk about. So I'm also very grateful for that. I'm just going to share my slides, and please do let me know if you don't see them. But really today I'm going to try to take us on a bit of a tour from all the way where we started in 2020, but focus more on, of course, the recent literature and I think where we are now, and I'll highlight some areas where perhaps we still need new research. I know many people, myself, would love for COVID to be completely over, but of course we're still seeing cases and still seeing some of the longer term sequelae. And so we'll focus a little bit on that and focus on some of the knowledge gaps. So a little bit of a backstory. In early 2020, I was actually on maternity leave, which was an interesting time to be on maternity leave because I was outside of the hospital in a professional capacity and had the ability though to of course follow along. And I think some of the things that I reflect on from that time was, of course, it was a very difficult time for many of us personally, and of course those who were in the hospital, but the amount of data that came out in such a short amount of time was truly unprecedented in our professional lifetimes, at least. And it's really incredible to look back and to think about how fast some of this data came out and how many things we learned very, very quickly. And so these are figures, of course, Kaplan-Meier curves from two different papers from cohorts in China from, again, very early in 2020 that started to report on cardiovascular injury in patients who had COVID. And these were generally very sick patients who, of course, their kind of clinical presentation predominant with their respiratory symptoms and many of them are in the ICU. But there was emerging data very, very early on that many of these patients, or a substantial subset, had troponin elevations. And not only does that, of course, signify that there was evidence of myocardial injury in these patients, but that was an adverse prognostic marker. So you can see here that the patients, again, with very typically severe COVID-19 illness, if they had evidence of cardiovascular injury, or cardiac injury rather, due to elevated troponin levels, that they did worse. And so here's a review article also from 2020. And again, I reflect back and really commend the authors for, we knew relatively little at that time. A lot was changing, and they got a lot of things right. And so really this figure kind of tries to summarize some of the hypothesis on the mechanisms of COVID-19 related myocardial injury. And this was really around the time when there were multiple grant calls to try to understand cardiovascular injury, what was going on in the heart in these patients. And I think really now we know that a lot of the underlying mechanisms are either related to non-ischemic inflammation or myocarditis, and as well as ischemic type pathways. Some of the things that I'm very interested in are, reporting or looking at sex differences. And so, we also learned very on that men who had SARS-CoV-2 infection were at higher risk of outcomes, adverse events than women of the same age. And so there were important sex-related differences. And some of this was driven by probably underlying differences in comorbidities in men versus women. But still, there are some unknown questions about this. This was a large study of over 11,000 patients, and you can see again that they stratified their analysis by men and women, which in general I think is really important that we do to try to understand these sex-specific differences. And you can see again that men had worse outcomes, including death, but also when we look at the cardiac outcomes, so those who had heart failure and ischemia, were slightly more common in men, again, even in matched analysis. Here's another analysis, again, from that very large pooled study, where women had lower odds than men of cardiovascular complications, even after adjusting for their age and underlying cardiovascular disease risk. And so, again, I think this is a really important lens to keep in mind as we look at some of the other data. This is an infographic adapted from a review paper I published in Radiographics with one of our really outstanding former fellows. And this was kind of interesting to reflect on for me at RSNA, because last year this was an educational exhibit, and now, of course, it's published in Radiographics. And it was, one of those papers, again, COVID related, which was once we were invited, it was, all pedal to the metal to try to get it published as soon as possible. But, really, I think now in 2023, we understand that there is some direct cardiovascular damage, perhaps in very sick patients, and early on, where there was a lot of interest in trying to identify SARS-CoV-2 virus within myocytes or within the heart tissue for those who had biopsy or even autopsy. But really now we understand that indirect cardiovascular damage is much more prominent mechanism, and multiple, again, hypotheses or potential mechanisms that could drive this. The systemic inflammation leading to supply-demand imbalance, similar to other ICU and very sick patients. The potential for this pro-inflammatory state to induce plaque rupture, which would again tie into the fact that we knew that people who had underlying cardiovascular disease tended to do worse. Then potential cytokine storm, and then lots of interest in endothelial dysregulation and dysfunction, potentially leading to a prothrombotic state. And you can imagine that might tie into the narrative where we knew that patients who had increased risk of venous thromboembolism, for example. Some data suggest there was increased risk of pulmonary embolism, but also this could affect, of course, the coronary arteries as well. There was relatively limited data early on acute COVID-19 manifestations. And, this is perhaps no surprise, of course, our IPAC and our infectious disease teams were working in overdrive. And I know, once I was back in the hospital for maternity leave, I had written a couple of grants and we started trying to recruit patients. And there was a lot of resistance, understandably, to putting patients who are still acutely infectious in our scanners. And so, some of the case reports, this one was just, a single patient, got a lot of attention because, this patient, I believe, was scanned with MR, of course, before they understood that they were acutely infectious. But you can see here how much, extensive inflammation and really diffuse inflammation there is in the myocardium. And so, again, limited data early on, and now we have a little bit better sense that, this non-ischemic inflammation, largely myocarditis, really is one of the more predominant mechanisms in the subset of patients who have cardiovascular injury related to COVID-19. So just a reminder, when we're thinking about acute myocarditis, we often thought about a upper respiratory tract infection as a trigger, but really the actual damage in the heart, the injury to the myocytes and the edema, is mostly driven, or almost exclusively driven, by the host immune response. And that can get triggered by various causes, including vaccination, as we now know, including SARS-CoV-2, among other viruses. And so as patients recover, the vast majority go on to a subacute phase over days to weeks, and in some cases months, where we have less edema but increasing fibroblast activity, which of course can lead to healing with some focal fibrosis, and that potentially puts patients at risk of arrhythmias and even heart failure, depending on the extent of that. There's a small subset of patients who will go on to a dilated cardiomyopathy phenotype, and of course we know that in patients who have dilated cardiomyopathy identified on imaging, chronic or remote myocarditis rather is one of the potential underlying causes. And then there's a even smaller subset of patients who go on to have chronic myocarditis, where they may have persistent or even recurrent inflammation, which can of course drive further fibrosis. And so really that's a very poor outcome, which we want to both identify and hopefully have options to treat. Biopsy was used relatively infrequently in patients who had COVID, of course, both due to the inherent risks in this invasive procedure, but also because these patients tended to have multi-system problems, particularly those that were in the ICU. But there are a few biopsy results, and this is a case which is not actually related to COVID, but is a confirmed lymphocytic myocarditis. And for those of you that are perhaps trainees on the call, I definitely recommend you make friends with your cardiac pathologist. They always have the best cases, and I always find that imaging pathology correlation to be really important. So I just want to highlight, though, that biopsy can establish a definitive diagnosis, but really is infrequently done in the current era, unless the diagnosis is in question or the results are thought to change management. In terms of imaging, really this chest pain guidelines that came out last year really played an important role in establishing cardiac MRI as an appropriate imaging test for patients with a suspected acute myocarditis. Of course, we had society statements and other guidelines, expert consensus guidelines that had said this, but really this was kind of the first, very large multi-society document that came out saying cardiac MRI had a class 1 recommendation in this particular scenario. And so I think this was really important for the cardiac MRI community, really to highlight the role of cardiac MRI. And we'll talk a little bit about the value that this adds in this scenario. So when we're talking about myocarditis, the key findings that we're looking for in cardiac MRI, and particularly focusing here on the tissue characterization sequences, because really that's the added value cardiac MRI provides above echo, for example, where of course we can get an evaluation of whether there's a wall motion abnormality or whether the global function is impaired. But really here, cardiac MRI allows us to actually see evidence of that myocyte injury and edema. So the typical pattern, like the most common one, which we would see, would be subepicardial LGE with corresponding edema. So here in a black blood T2 weighted sequence, but of course we can also quantify this on our T1 and our T2 maps, and I find those are very powerful in myocarditis for helping us to confirm edema when it may be subtle on our qualitative sequences, but also to track changes over time, and we'll talk a little bit about that near the end. When we follow these patients up, as I said, the vast majority have resolution of their edema. Here, this was a 3-month follow-up where there is no longer edema, or T2 has completely normalized. And you can see that the extent of LGE has decreased quite dramatically, but this patient has healed with some minimal residual LGE here in this context. Again, outside of the acute myocarditis phase, when we no longer have edema, we know that this reflects fibrosis. And so really important not to interpret LGE in the acute myocarditis phase as equaling fibrosis. It doesn't. In the acute phase, this is telling us about myocyte injury, which can heal as fibrosis. But again, they are actually reflecting different pathophysiologic processes, and that's really important to keep in mind. When we're looking for non-ischemic inflammation in the heart related to COVID or vaccine or otherwise, most centers are using the revised Lake-Louise criteria, and I love these criteria. I wasn't part of them, so I'm not biased in this way, but I find them very helpful because they're very straightforward. You can meet a T1 based criteria, including our LGE or even our T1 maps and ECV, and you can meet T2 criteria in a number of different ways, or traditional kind of black blood T2 weighted imaging, for example, or T2 maps. And really, if you fulfill any of the T2 criteria and any of the T1 criteria in that appropriate clinical context, so usually in a patient with acute onset of chest pain and troponin elevation, that provides strong evidence of myocardial inflammation. Of course, you're looking for regional and global systolic dysfunction and maybe signs of associated pericarditis, but you don't require the area. It's consistent with evidence of myocardial inflammation, but perhaps possible. And often we'll see this if you do your weeks after symptom onset. So for example, if a patient is followed as an outpatient and they're not booked for a number of weeks, if the edema has resolved, you may not meet T2 criteria, but if that T1 abnormality is in a consistent pattern, as we talked about before, then you might still have evidence of myocarditis. One of the reasons LG is so important is, again, this is non-COVID data, but just to set the stage, is that it's such a strong adverse prognostic marker in multiple cardiomyopathies, but here showing data from patients with myocarditis. So we know that if you have leak-edema enhancement and you meet clinical criteria for myocarditis, you have worse outcomes than if you don't have LG. And really, this is a marker in the acute phase of myocyte injury. So what does COVID-19 myocarditis look like? Well, we had a very large number of cases that, we're a very large center where patients were referred for COVID-19. And of course, we're a very large cardiac MRI center. And so we had a large number of referrals, many of which were normal, or we saw no evidence of COVID myocarditis, but some cases, which had a classic history of documented SARS-CoV-2 infection, followed by acute onset of chest pain, and very classic findings of myocarditis on cardiac MRI. And here's, one example where we can see the function was relatively normal, but here's this subepicardial edema on our T2 weighted imaging and LGE. And this is a very small area, but very classic location, and again, concordant findings between both our T1 weighted and our T2 based criteria. So what do we know about myocardial inflammation in the early phases of COVID? Well, this is one of the studies we published in our group, and I just want to highlight that this was really a lovely collaboration between both radiologists and cardiologists, and as well as our laboratory medicine colleagues, and of course experts in nuclear medicine. I do a lot of work in PEDMR, but we really are a team, and we have such a fantastic, supportive and collaborative research environment. So I really want to stress that this was teamwork, and really working together, we were able to achieve this relatively quickly. And so what we did is we recruited patients who had recovered from COVID-19 about 2 months after their infection. So again, outside of that acutely infectious phase, where we had originally wanted to recruit patients, but as I said, there was hesitation both from technologists and leadership teams in terms of exposing people unnecessarily to SARS-CoV-2. And so in the end, we settled on this kind of healing phase. And what we did was we did FDG PEDMR, similar to how we would image our patients with our sarcoid protocol. So all of them had glucose suppression with that appropriate diet. And what we found is at 2 months, a very small proportion had focal FDG uptake, suggestive of metabolically active cells. And usually in sarcoid, that tells us about acute inflammation. And so, this was, of course, one of the first studies post-COVID where, we were looking at this. And what we found is not only, did we see this, but the patients who had inflammation also had corresponding abnormalities on their MR. So, more LGE, they had higher parametric mapping values, lower ejection fraction, but also they had higher systemic inflammatory blood biomarkers. So really everything kind of going together to suggest that what we were seeing on FDG really was reflecting metabolically active inflammatory cells in that context. We brought all of these patients back because we were very interested to see these were all patients who had COVID. Some of them, were quite unwell, but a large number of them had had milder infection and disease course. And what we did is we brought all of the patients back who had FDG. They had no intervening treatment in the meantime, so no anti-inflammatories. And interestingly, what we found is in all cases, everything got better. So in most cases, the FDG completely resolved. The quantitative uptake parameters all improved, as did all of their systemic inflammatory biomarkers. So really, I find this to be a very reassuring story that yes, we have evidence that there is some inflammation in the heart, again, in a small subset of patients after acute COVID-19, but it tends to resolve on its own in these patients. This was another beautiful study in a very large cohort of patients that looked at patients, within a relatively short time period after COVID-19. So these were patients post-discharge. And I really like this study for a number of reasons. One, they had a great control group that was not only COVID negative, but also comorbidity matched. And so that's really important because, of course, if you compare young, healthy people with older patients who have comorbidities, well, you may see a difference related to that due to confounding. I also really like the study because they described the LG in such a nice granular way, really how I think we approach this as imagers in our clinical practice, not, is there LG or not, but really thinking about what is the pattern? Does this fit into an infarct pattern or a dual pattern or non-ischemic pattern? And so they really categorized it in such a, fantastic granular way. And you can see here that the patients who had COVID and had a troponin elevation were more likely to have LGE. And this both fell into infarct and ischemic type patterns as well as non-ischemic. Interestingly, there were relatively few adverse events, and this did not differ significantly compared to the control. So there were differences in terms of the MR findings, but again, very low event rates, so relatively reassuring data. There was a lot of interest, in, I would say, in the past 2 years and ongoing onto longer-term cardiovascular outcomes after COVID-19 and identifying patients who are at risk of long COVID or, the various other terms that have been used to describe patients who have persistent symptoms. I remember when this paper came out in Nature Medicine in 2022, and, it was a big storm on Twitter, certainly, but I think also in our department, we discussed this quite extensively. And really, just to summarize this data, they looked at patients who had recovered from COVID and looked at their adverse cardiac events at 12 months. So this was, kind of one of the first longer-term cardiovascular outcome studies that we saw in a fairly large cohort of patients. And, the data showed us that patients were at increased risk of cardiovascular events above and beyond baseline. What I found interesting was when they stratified the analysis based on the underlying severity of disease. And so you can see that the patients who were really sick in the ICU with COVID were at highest risk. That makes sense and really was concordant with what we had seen clinically. But interestingly, if you look at the patients in green on the figure on the right, those are patients who had been non-hospitalized, so predominantly had mild COVID. And they were even that cohort of patients with a very slight but significant increased risk of adverse cardiovascular events. And so really, I think there was quite a bit of concern here in terms of what was going to be the long-term sequelae of all of these patients who had recovered from COVID-19. And here was a meta-analysis that tried to pool this data and looked at sex-specific differences. As I mentioned before, we knew that there were differences in the acute phase between men and women. Here they tried to look at the risk of developing long COVID or post-COVID condition as they defined it here, and found that actually female sex was associated with increased risk of long COVID. So, persistent symptoms, however those were defined, although when you look at the data, you can see how heterogeneous this is. So, the I-squared here is 94%. So interesting that we have, some data that suggests maybe perhaps women are at higher risk of longer term persistent symptoms after COVID and even cardiovascular events versus men who seem to be at higher risk in the acute period. So here's this summary figure, again, from this paper that I worked on with one of my fantastic former fellows, looking at potential mechanisms of longer-term cardiovascular injury. And I think imaging really has an important role in trying to help us understand what is driving some of these outcomes in patients who have persistent symptoms. And so, we know, of course, if you have fibrosis, that can be a driver of adverse events. Some patients seem to have persistent systemic inflammation that is ongoing for some reason, is not resolving even after the respiratory symptoms seem to get better. Lots of interest in endothelial dysfunction, potentially driving a prothrombotic state, even in the microcirculation, and other, systemic dysfunction and dysregulation. This was a study that came out fairly early on. Of course, many of you will know because it's now been cited thousands of times. And but I'm highlighting it here because even though it came out early, it was in a kind of a more longer-term follow-up. These were patients who were imaged 71 days post-COVID, so really outside of that acute post-COVID period. And these were patients, importantly, who had no symptoms. And this also caused a perhaps a sensation is even appropriate on social media and within the media in general, because of the very high prevalence of abnormal cardiac MRI findings that were reported. And you'll see that though a lot of these were driven by high T1 and T2 mapping values. And I just want to highlight that this COVID group is deeply phenotyped, of course, and that's very helpful to have this data, but you can see that many of them had underlying comorbidities. And so, when we compare to the healthy control group, that, that may not be the most relevant comparison, whereas they also had a risk factor matched control group. And I'm a big fan of mapping, and I do find it very helpful for, tracking changes over time and perhaps picking up more subtle changes. But, I really want to point out here that yes, the means were different between the COVID group and certainly compared to the healthy controls, but there is really a substantial amount of overlap. And so on an individual patient level, it's very hard to use this data, at least in isolation, to identify who has COVID-related myocardial injury and who doesn't. This was a beautiful study. I'm just showing you the summary figure from the group in London, really that looked at a group of patients who had much more severe COVID-19. These were patients who had troponin elevation. And again, I really like how they characterized them, not just in terms of LG positive or negative, but really looked at the pattern of injury. And again, they found a really high proportion of patients who had abnormal cardiac MRI. But again, this was a very narrowly defined subset of patients, not only who had severe COVID, but also had a troponin elevation. And one of the interesting findings that I think when you really dig into their data is they report that the troponin levels were not predictive of a diagnosis of myocarditis. And I think this is interesting because this suggests, of course, that troponin levels were also, or in addition to myocarditis, driven by something else. So potentially that supply-demand mismatch or imbalance or ischemic type injury as well. And so really kind of helped us to further understanding of what may be driving those findings. There's been a lot of interest and data coming out more recently, I would say in 2023 in particular, on linking or the association between cardiac MRI findings and patients who have persistent symptoms. And I think this is really of interest because those patients, of course, a small subset that have long COVID or post-COVID syndrome really can have, quite debilitating persistent symptoms and even very impaired quality of life. And so this was a kind of a larger follow-up from our cohort group of patients. Again, collaboration between the radiologists and the cardiologists, as well as others in our center. One of the findings that we reported in the study with over 100 patients who were imaged around 3 to 6 months post-COVID, but then followed for longer term, was that we found native T1 was the only cardiac MRI parameter that was associated with persistent symptoms, not only at 3 to 6 months, so concurrent with when they had their MR, but also at this much longer term follow-up at 12 to 18 months post-COVID. And that remained consistent even after we adjusted for clinical and demographic and other risk factors. And here we're, just showing you the data plotted between those who are symptomatic and asymptomatic at these 2 time points. And again, I just want to highlight that again, yes, there was a significant difference in terms of means, but substantial overlap between the groups. And so again, this data is perhaps interesting for us to think about from an underlying pathophysiologic level, because we know elevated T1 can reflect fibrosis and interstitial changes, but really on an individual patient level, very difficult to use these numbers in isolation to try to identify patients at risk. One of the other things we learned, of course, after COVID-19 is, vaccination, as this came out, as we were flooded completely with requests to investigate cardiovascular injury after vaccination. I just want to spend a couple of minutes on this. I won't dwell on it for too long, but I think it's really important to talk about this in the context of COVID-19. And here's data from our study when we were recruiting patients for PET-MR, and I still remember seeing this, and I called up my cardiology colleague Kopi, and I said, this was when vaccines were first rolling out in healthcare workers in Canada in mid-2021, and I said, well, this patient has unilateral lymphadenopathy and it's FDG avid. And of course, my mind as a radiologist was first going to, does this patient have an occult breast cancer? And then when we called up the patient, she said, well, I had my vaccine the day before PET-MR. And so actually we wrote this up, and I have to say, as a case report, this is such a highly cited paper from our group, which I, find kind of funny in the context of all of the original research we've done, but really was one of the first papers to show that, patients have unilateral lymphadenopathy after vaccination, but when you follow them up, this goes away. And, of course, this is obvious to everyone now, but I think really highlights the value of having data. And this was, of course, a bit of a serendipitous finding that we happened to pick up based on when this patient was imaged. But really now, of course, we know that there is a risk of myocarditis after vaccination, which is higher in younger patients, particularly younger men. This also depends on the vaccine, type as well as dose, and certainly more common in patients after the second dose, and that is likely related to that shorter interval when patients were getting their vaccination, much shorter interval between first and second doses. And I'm showing you this image, you've seen myocarditis cases now already in my talk, but really to show you that this could be any myocarditis. So the pattern of injury is remarkably similar regardless of the trigger. And so the clinical history here is so important. And so for us, individuals who are imagers, and really it's important for us to have, that clinical history, that patient presented with chest pain after vaccination to try to understand the trigger. And I think this is very important for patients as well. But again, very typical findings of myocarditis from any cause, subepicardial LGE and subepicardial edema, corresponding T1 and T2 mapping abnormalities here. And one of the things that I was really interested in is what is the risk of myocarditis or myocardial injury relative to COVID-19 itself. And so we had great data here. This is clinical data published in the New England Journal showing us that absolutely the risk of myocarditis we know is higher after COVID-19 compared to after COVID vaccination. And really, when you look at all of the cardiovascular outcomes, this relationship, is true. This is data from our group where we actually took a group of patients who had met clinical criteria for myocarditis. They also met Lake Louise criteria on MR, so all of them had MR. And what we did is we compared the groups, so those who had myocarditis following COVID vaccination, those who had myocarditis following SARS-CoV-2 infection, which had to be documented, and those who had other causes of myocarditis. And really this was one of the first studies to do this and show that the vaccine myocarditis group had higher ejection fraction and lower T1, so less severe abnormalities on MR, and a lot of this was definitely driven by the fact that these tended to be younger and healthier patients. But when we looked at actually the pattern of injury, again remarkably similar, so between COVID and post-vaccine myocarditis, again most commonly we were seeing that injury at that basal to mid infralateral wall, similar to other causes of myocarditis. I think it's really interesting to think about, how do the imaging findings relate to outcomes? And a lot of my research program, even pre-COVID, focused on this. And so this is clinical data, but I think it's really interesting. And I love this paper. It came out in JACC in late 2022. And so what they did is they looked at, both outcomes as well as resource utilization in myocarditis post-vaccination and in kind of viral myocarditis, so the kind of that comparator group, and showed here very, I think quite convincingly that the outcomes were better in post-viral myocarditis. So again, linking to the findings that we saw in our MRI study, where the MRI findings were less severe, but again, also the outcomes. So again, fairly reassuring, message. I know it's very, worrisome, and we were, quite concerned when we started receiving hundreds of requests for MRI post-vaccination in patients, and who were worried. And certainly, I have young children, so I know many parents were worried as their, young adult and adolescent children were getting vaccinated. But we do have more data now to absolutely support that there is an increased risk in certain groups, but this is fairly minimal increased risk above baseline. So one of the follow-up studies we did, and I have to say this study was really only possible because we had such a fantastic COVID research group infrastructure in place. We had already recruited very successfully for our COVID PET-MRI study. And so once we started hearing about the myocarditis post-vaccination, we're able to pivot almost immediately, get REB approval very quickly to start recruiting patients for PET-MR post-vaccination. And so, really sometimes having your team in place is so incredibly important. And so we recruited patients for PET-MR after vaccination. And one of the things we had learned from COVID data, both from our own experiences, but from other groups as well, is really the importance of having comparator groups to compare the data. And so here we recruited patients both who met criteria for myocarditis after vaccination, but also a group of symptomatic patients who had not met clinical criteria, and a group of asymptomatic patients who, self-volunteered. And so again, there is the potential for some selection bias here. But what we found is that those latter two groups of patients, the ones who are asymptomatic and the ones who are symptomatic but did not meet clinical criteria for myocarditis, had no evidence of FDG uptake, so no myocardial inflammation in their heart. They had some non-specific, minimal abnormalities on cardiac MRI. But there was a small proportion of patients post-vaccination who had persistent inflammation. So this was one of the first reports of, certainly metabolic data post-FDG uptake. But I think in general, the kind of perhaps more important message that came out of this body of work is that we did not see abnormalities in this asymptomatic group. And, I think there was, a press release that followed this paper, perhaps because there were patients who were worried about the potential for subclinical myocardial injury. And so I do think it's important, though, that we, potentially continue to follow these patients, really to understand what are the longer term implications, particularly those who met clinical and imaging criteria for myocarditis. What is the risk of future myocarditis with COVID-19 vaccination or other vaccinations? How many of them will go on to have adverse events? We know there is a small risk of developing heart failure, particularly if you have LGE reflecting fibrosis in that follow-up period. I do really want to stress, and I know I talked a lot about sex-specific analysis, and this is hard in some cases when individual groups were publishing their data and may not have had enough sample size to stratify the analysis by sex. But I think this is really important because we have data to suggest that men and women have different outcomes at different time courses of the disease. And so, I'm also speaking to myself because some of our analysis did not have adequate group numbers to really dig into that. But I think it's very important that we try to do that either by pooling data or working together. And again, I really think there's some unanswered questions about identifying patients who are at risk of myocarditis before it happens. So beyond just saying, well, younger men were at risk of myocarditis after vaccination, which ones, because we know it was a small proportion, to try to help us understand the underlying mechanisms. And of course, in case we are ever in the situation of another mass immunization campaign, but also understanding in the COVID context who is at risk of persistent symptoms. And hopefully I've set the stage to convince you that I really think imaging plays such an important role, particularly MRI, and not only picking up some of these acute and longer term changes, but really helping us to understand the underlying mechanisms of disease. So with that, thank you. I know we went a few minutes over, and my apologies for that, but I really appreciate the opportunity to be here today, and I will stop sharing so that I can answer any questions.
Thank you very much. Fantastic presentation. Incredible data and images shown. Also long-term follow-up data. Which brings me to my first question. When I may ask you. So, what is the longest term follow-up that we have currently available? It's 1-2 years, or?
Yeah, so and it's a great question. So the clinical follow-up data, we have a bit longer. There's a few cohorts of patients. Well, the New England Journal one I mentioned is, of course, 1-year follow-up, but there's now cohorts of patients that have been followed clinically for 2 and even 3 years. And so I think we have some data from those. But to my knowledge, the longest follow-up data from MRI, really for thinking about that progression of MRI findings, is about 18 months. And so I do think we need longer term follow-up, absolutely, because I'm very interested in the trajectory of those changes. If someone has a small amount of residual LGE, does that stay stable? And of course, does that predict who might have an arrhythmia event? Still some unanswered questions.
So you plan to follow up your patients again? You will invite them for another MR?
Exactly. So we have clinical follow-up, which is ongoing, and hopefully we'll look at that based on the baseline MR. And then there is data where we're bringing back patients again who had an abnormality at baseline, and I really do think those longitudinal changes will be important.
Okay, thank you. Robert?
Thank you, Kate. Excellent presentation. I liked your images as well as your data. Just terrific.
Thanks.
So I would start with one question from the chat. So it's from Małgorzata from our radiology clinic, and she congratulates as well for your presentation. And she asks, do you add stress perfusion per default to your COVID CMR protocol? Or if not, where should we use perfusion as well?
This is such a fantastic question. So thank you for asking it. And I'm glad I included the studies that did do perfusion. So in general, we do not routinely do stress perfusion in our patients post-COVID. We have followed kind of more of what I would call our myocarditis protocol, where we are focused mostly on detecting edema and detecting, of course, LGE and our mapping changes. This is partly practical. Work in a public healthcare system, and there is a lot of scanner pressure. And so, of course, can do that type of protocol very, very quickly, certainly in under half an hour. There are some logistical challenges, just how our bookings work in terms of booking patients for stress, which, of course, need someone on site. So many of our myocarditis patients who are outpatients would get scanned in non-monitored spots. And so obviously just a much larger pool of patients. So we do not routinely do it. But I think your question is so on point, because I showed you that there's data that these patients can have ischemic injury. And so really we would have done that. A small group of patients would have been triaged for stress perfusion if the clinician suspected ischemic injury. So really this was driven by the clinical history, patients who are presenting with that more ischemic history in terms of how they presented with their chest pain. Certainly if there was known underlying coronary artery disease, and there was a question about potential plaque rupture, I would say this was a small proportion of our patients. But other centers, as you saw, the data from the London group, certainly they did a lot more stress perfusion and did pick up some abnormalities. The number, and again, this is a bit from memory, but from my memory from reading that study, is there were relatively few patients that only had abnormalities on stress perfusion. And so, I'm fairly reassured that perhaps there were some more patients we might have picked up who only had a stress-induced injury. But by and large, really we found that the predominant abnormality, at least in our cohorts of patients, was driven by edema, and in my mind leading to LGE and myocyte injury. And so it's a great question. I don't have specific criteria for you, but at our center we did not routinely do it. So really I would consider it if you're thinking that there is either a microvascular dysfunction or epicardial coronary disease driving the underlying myocardial injury.
Thank you.
Thank you.
Yeah, my question is, you said to Hatem that your longest follow-up is 18 months, more or less. Do you see any differences in presentation or images on CMR over the time period? If there maybe more edema at the beginning, and now with the newer strains, it looks different, or what's your opinion?
I love this question, and I did not tee it up, but thank you for asking it. So I think there's like a lot of interest, and this is something I'm really interested in. I'm going to start by taking a step back and kind of tangentially answering your question. I will get to it, but we have absolutely seen a difference in referral patterns, and I think that's important to acknowledge. So, certainly early in COVID, when data about cardiovascular injury came out, like we were flooded with inpatient requests from very sick COVID-19 patients, and those are very hard, to get in our inpatient slots, but also because the scanner has to go through a full clean after, and so really had to kind of create protocols for who would get inpatient cardiac MRI in that acute infectious phase. And then again in 2021, when literally it was a flood of requests for cardiac MRI at our center because we did so much myocarditis work before, perhaps, for post-vaccine myocarditis. And so we have certainly seen a dramatic change in referral patterns where it's a rare day where I'll see a post-vaccine query myocarditis coming through the protocol. They are still coming mostly in my mind because of that difference in interdosing interval. Of course, patients are still getting boosters, but typically many, many months after their last dose. I do think, to answer your question, there's not robust data in terms of MRI differences in pattern of injury, with different variants, for example. But anecdotally, absolutely, I think this mirrors what we've seen clinically, is that patients are not getting, the majority of patients are not going to the ICU. They're not as unwell systemically, either because of immunity, vaccine induced or otherwise. And so certainly I think we are seeing less severe myocardial injury on imaging, but I have actually not seen published data, to report that. And I think one of the challenges now, and perhaps you found this as well, is, in Canada, almost nobody's getting PCR anymore. And so it's very difficult to track the strains, of course, and to try to actually do research on that unless you were, somehow robustly, prospectively following patients.
Okay, thanks. There's just popped in another question from the chat. So did you do strain imaging on post-COVID patients?
Yes, absolutely. It's a great question. I have an on-the-fence relationship with feature tracking strain. I think it's really interesting as a research tool, and we do it, and definitely we did in both our COVID cohorts and our post-vaccine cohorts, and found, as you expect, that there were subtle changes that tended to track with edema, certainly tended to track with LG. You've seen this in other patient populations, and so I don't think there was any surprises there. I am not convinced, and I've not seen convincing data either in our cohorts or otherwise, that strain is useful to pick up injury that you would not otherwise. And so, in my experience, it tends to track with all the other tissue characterization changes. But yes, absolutely, we did do it, and we did see some changes. And so we haven't routinely integrated it into our clinical protocols, but certainly for research. And I think it's a great question. That there are other groups who really think that it might pick up earlier, more subclinical disease. But I have to say, in our experience, it really tracks along with the tissue characterization findings.
Okay, thank you. So
one of the things I can just interject that I meant to mention before, but I think from kind of a learning point, and this was really eye-opening for me as we were kind of recruiting patients, is the amount of social media interest, I think, from the general public, particularly on the post-vaccine story. And it was actually quite remarkable. At one point, I thought my research coordinator was going to quit. She was getting so many emails, and some people very, very angry, and kind of conveying, of course, their political views and such otherwise. And so I know we talked about Twitter a bit at the beginning, and so I also experienced this, I think, possibly to a lesser extent, because of course her name was on the posters as we were recruiting. And so this was very interesting experience for me. Certainly in my prior work on non-ischemic cardiomyopathies, there was never that much public interest, I would say. And so it's a bit of a double-edged sword, of course, in terms of treading carefully, and was really cautious there for a while in terms of just reporting really factually the data that we have. And so that was another kind of, I think, a lesson learned in terms of when there is so much heated interest and emotion in the public sphere, one, we had a large amount of interest in our study, and really we're getting requests faster than we could even scan patients at some point.
Yeah, thank you very much for sharing this experience. I think it's an experience that we also made, perhaps to a lesser extent. But we also got emails from patients from everywhere, from the US, and they wanted to have an MR in Zurich for proving, the bad effects from vaccination and so on. So it's obviously it's more than just a disease.
Yeah.
So many emotions and political issues associated
absolutely.
with it. Okay.
Yeah, and people desperate for answers, I think, at the end of the day. Yeah.
Okay, now we are desperate for questions, actually. Okay, so I don't see any question anymore in the chat. Robert, do you have something? Everything clear? I still miss a good CT paper on myocardial abnormalities in COVID-19, but
Yes, I know. Well, I'm sure those of us that were reviewing papers during that time, it was an interesting time. As I said at the beginning, there was such a flurry of data that came out. No variable quality, of course. I think there was a lot of interest in publishing very quickly early on, and for me, I really do think there are still some unanswered questions that I tried to highlight. Where I think we have some gaps, and I'm really interested in kind of thinking about the data that we have, or the data I think we ought to get, in terms of thinking about the future. If we were to have another pandemic, which of course there's some natural cycle to this, and maybe not in our lifetime, but certainly in our children's, that's a possibility. And so really trying to take the data and understand. So those those questions about who's at risk, we really don't have good data beyond age and sex, which is such a big category. And so I really hope that the funders and researchers, including this group, continue to look at that data and that long-term follow-up data. So I think there's more to be learned.
okay. Yeah, thank you very much. Thank you again for this fantastic presentation, wonderful images and data, for this vivid discussion. We are now close to 6 o'clock in the afternoon, so we will go home now. I'm sorry for you that you have half a working day in front of you, but
that's great. It was
this is how it is. So I hope we will see you perhaps in Vienna at ECR, or on another occasion. I don't know, SCMR in London, perhaps.
Yeah, I'll see you there. Wonderful.
Yeah. So
okay.
Robert will certainly be there. Me, most probably not.
Oh, okay.
So thanks again. Before closing, I want to announce our next speaker in this cardiovascular imaging grand round, which will be Rodrigo Salgado from Belgium. On the 18th of January 2024, he will talk about CT imaging in TAVR patients prior to and after valve implantation. Before we go again back to Toronto, actually, in February, where Bernd Wintersberger will talk about cardiotoxicity and again, cardiac MRI data. So thanks to everybody. Thanks for participating. Yeah, goodbye.
Bye.
Thank you very much, and see you soon.
Bye.
Bye-bye.
See you soon.